Hello, good evening, everyone. Welcome to the Melanoma Research Foundation's Ask the Expert series. My name is Miriam Kadosh. I'm Director of Education and Patient Engagement at the Melanoma Research Foundation. And we are pleased to have you join us today for our wonderful educational opportunity entitled My Melanoma Therapy Stopped Working. What's next? Our goal today is to discuss and understand how well immunotherapies work for newly diagnosed melanoma. We will also discuss treatments being developed for patients when immunotherapies either stop working or the therapy leads to intolerable side effects, including clinical trials and other options for patients. Our mission at the MRF is to eradicate melanoma by accelerating research while educating to and advocating for the melanoma community. We know that education is critical for patients to make informed decisions about their care. We are very grateful to Replimune for their generous support of this webinar series and investment in the MRF's mission. A bit of housekeeping before we get started. We encourage you throughout tonight's webinar to use the Q&A box to ask questions. You can ask them throughout the session. The information presented during today's session is for educational purposes, and any individual treatment questions should be directed to your healthcare provider. We encourage everyone to visit melanoma.org to learn more about the resources that we have available. And also, this session will be available for viewing later as part of our videos on demand library that you can share with others. We are going to get started. Today, we are joined by Dr. Michael Postow and Benny Lunsford. Dr. Postow will begin the session, followed by Benny, and then time for Q&A. Again, we are grateful for the support of Replimune and will now have Courtney Kramer, Director of Medical Affairs, Education, Training, and Insights, introduce our first speaker. Courtney?
Thanks so much, Miriam. And thank you all for joining us this evening. So I want to give a special welcome and thank you to Michael Postow and a little bit of background about Dr. Postow. He's a medical oncologist and the chief of the melanoma service at Memorial Sloan Kettering Cancer Center. He led the first randomized trial of combination immune checkpoint inhibition, nivolumab plus ipilimumab, resulting in its FDA approval. He has also written and presented on topics related to immunotherapy outcomes and side effects, and studied new ways to combine immunotherapy with local treatments, for example, radiation. His completed and ongoing work continue to impact cancer patients and advance immunotherapy for melanoma and other diseases. He enjoys skiing, outdoor activities, and trying to keep up with his 2 toddlers and his triathlete wife. So with that, I will hand it over to Michael Postow.
Thank you very much, Courtney and Miriam and the rest of the Melanoma Research Foundation and Replimune for allowing us to have this conversation tonight. And I'm really hoping this 20 to 30 minute discussion will spark some interest, provide a little bit of background into how are the different melanoma treatments being developed and how we think about them along the treatment trajectory, and really a great educational opportunity for all of us this evening. And looking forward to all of the questions that you might have afterwards once we get started, and also our patient guest that will be sharing his experience as well. So with that, I will go ahead and share my screen and get started. And so this is a topic that was presented as what to do if immunotherapy is not working for melanoma. But I think more broadly, I'll talk about what we think about with the melanoma treatments that we have when we're treating patients with melanoma and what the options are for first treatments, why we think they might be effective, and what to do if they aren't effective, or how do we think about that and how we are moving the field forward in this respect. And with that in mind, I do want to make sure that we have plenty of time for questions and discussion. So I'll make sure that this part of the talk is over certainly by 7:30 at the absolute latest. These are the disclosures that I have for relationships with different companies that make melanoma drugs in the field. A lot of this is for clinical trial support for new agents and testing of new agents at the institution where I work, and for some advisory boards that I participate in from time to time, offering back and forth advice on different trial designs and new opportunities for melanoma patients within different companies' portfolios. So many people think about melanoma, and the first thing I think to think about before we even talk about treatment of melanoma is, what is melanoma in the first place? And this is an obvious melanoma on the skin, and some people have melanomas that present like this, where there is an irregular shaped mole. Some people have melanomas that don't look like this at all, where it might just be a tiny little pink mole, or maybe no discoloration at all and just look like a normal mole and still be melanoma. And some people have melanoma that shows up inside the body that never ever was detectable on the skin. And that's called melanoma of unknown primary, likely because it was so microscopic that even the best dermatologist checking out the skin every single day would have never detected it. So this is a classic melanoma. It has irregular borders. It has different types of color within this. And this would be something that a dermatologist would see and hopefully biopsy and make the diagnosis of melanoma. But it's important to think about, well, what is melanoma and where does it come from, and why does this problem exist? And when we think about melanoma, if you break down the words, oma means growth, and melana or mela is a black growth. So it's a growth of cells that actually make pigment in the skin, and pigment is the coloring of your skin. So this is a cartoon that shows the different layers of skin, or epidermis, which is on the outer layer of the skin. And then there's the dermis, which is the deeper layer of the skin. And all of these little cells here in yellow with these purple nuclei, I'm taking it back to 7th grade biology. So bear with me a little bit, but I'll keep this, on the level that I think will be interesting, hopefully. Normal skin has these cells called melanocytes that live at the bottom level of the epidermis, just above the dermis. And these melanocytes are like little, it's like a little octopus. And you can see there are all these different tentacles that extend from the melanocyte upward through the skin cells. And the idea of a normal melanocyte that ultimately could give rise to melanoma, but the normal melanocytes that live in our skin release little packets of melanin, and you can see these little tentacles releasing these little pink packets of melanin, or these little melanin granules, these little brown spots. And what these little brown spots do is act as a shield for the DNA of these skin cells that are at the bottom of the epidermis. And those little melanin packets are intended to be like an umbrella that protects those skin cells from ultraviolet light that is beating down on our skin every day of our life. And when you get a tan, which hopefully no one ever does, because we know that getting tans is not a healthy thing to do, despite some of the societal pressures in that regard, but we're trying to avoid the ultraviolet light. The idea of the ultraviolet light and tan is that these melanocytes work extra hard, producing extra melanin, and therefore pigmenting the skin or darkening the skin a little bit to shield the DNA of these cells that are at the kind of lower part of the epidermis here. And so that's what happens when melanocytes are working hard and your skin gets brown. So the melanin is trying to protect the skin cells. It's a defense mechanism against the insults of the ultraviolet irradiation. Now, what happens with melanoma is, for reasons that we don't completely understand, these melanocytes, that they live in the skin, but these cells are actually all throughout the body. They're inside the mouth, they're in the digestive system, they're in the vulvovaginal area or in the anorectal area sometimes, or even in the back of the eye to cause uveal melanoma. But for reasons that we don't completely understand, there are different mutations or changes in the DNA of these melanocytes that then give rise to melanoma. And when they grow out of control or move to other parts of the body, when they spread from different places, that's called melanoma. And that's when this melanocyte kind of goes rogue. It spreads down into the dermis below where it lives in the epidermis. And that's when people have issues related to melanoma. But I think understanding where melanomas come from is really important in this octopus-like cell that's intended to give our skin pigmentation and also protect the skin against ultraviolet light is the origin of melanoma. So it's from a normal cell in the body that's everywhere. And for a long time, we thought of melanoma as a particular type of cancer in that it was a disorder of dividing cells. So normally when our cells in our body split, they undergo something called mitosis, but they split from 1 to make 2 and then 2 to make 4. And if a cell recognizes there's something wrong with itself, what it should do is say, well, there's something wrong with me. I'm just going to stop growing and I'm going to stop dividing and I'm just going to self-destruct or undergo something called apoptosis, which just means self-destruction. It says, I'm not supposed to be here. I'm going to just go away. And that's the normal way that the body works. So if this is a melanocyte undergoing division to make 2 melanocytes, and then this one's becoming more, if there's something wrong with the melanocyte, it should say, oh, something's wrong with me. I'm not going to make another one and just destroy itself. But what happens with melanoma is that it doesn't abide by that rule. And it continues to divide and continues to divide. And the abnormal cell will just keep growing and keep dividing. And we'll talk a little bit about this later, but one of the kinds of melanomas some people have is called a BRAF mutant melanoma, BRAF, or an NRAS mutant melanoma, NRAS. And those are mutations in the cells that allow them to keep growing and keep dividing, even though the normal signals to tell them to stop are not present. And there are drugs that are being given or tested for patients with BRAF and NRAS kind of melanoma to try to stop this division and stop this growth because of those particular mutations. But that's one way of thinking about melanoma and thinking about cancer. And the other way to think about it is through the immune system. And I'll get to that in the next slide. And this was just a slide to tell you what I was telling you before, that the BRAF melanomas can be targeted with pills called targeted therapy to stop them from growing. And this is a pathway of the BRAF mutation. It's a signaling pathway in the cell. This top is kind of the barrier of the cell. And essentially what happens is that when BRAF or NRAS is overly active, it triggers a cascade or a waterfall of actions of different proteins that ultimately go down to the bottom. And this is a strand of DNA, a double-stranded helix that you can see of DNA that gets replicated and divides. And when we give drugs people might be on called BRAF inhibitors or MEK inhibitors, BRAF inhibitors like vemurafenib or dabrafenib or encorafenib, or MEK inhibitors like trametinib or cobimetinib or binimetinib, those drugs block this pathway that's caused by this mutation BRAF and therefore disables this growth pathway that's causing all of this division. And so this is one reason that we give some of the targeted therapies initially for patients with melanoma. And these drugs can really work incredibly well. This is a patient's PET scan on the left that took a BRAF inhibitor, published a little over a decade ago. And on this PET scan, you can see the areas of dark black are areas where there's extra hypermetabolism. So the brain at the top of this PET scan is always hypermetabolic because people are always thinking and there's a lot of activity going on. But all these other spots throughout the body are little melanomas that have spread from this particular patient. And day 15 on the right is just 2 weeks basically of treatment with BRAF inhibition in this particular case. And all those black spots have gone away or substantially reduced in this particular patient. So showing us the power that if you block the BRAF, you can help improve survival and shrink a lot of melanoma tumors. And that's a really wonderful advance. The other big advance of melanoma treatments beyond the BRAF story, I alluded to it a little bit earlier, was immune therapy advances. And this is a picture from, if you look at the bottom, it says R&C Hospital, which is actually the hospital for patients with bone and soft tissue disorders. 1892 is when this picture was taken. And this is from the Christmas party, actually. If you look, it's kind of cut off here. It says Xmas party. So obviously they weren't having a whole lot of fun in 1892 at the Christmas party. They were quite serious, but that's how they took pictures at the turn of the century at that time. But this is William Coley, and he had discovered that patients that had sarcomas and bone tumors, this gentleman here was from a medical publication over 100 years ago with the tumor on his neck. When patients had infections post-operatively, and that happened all the time back then because they didn't wash their hands and use antisepsis like they do currently, patients would get infections and that bacteria infection would cause the immune system to rev up and people would have fevers and feel really miserable. But in rare cases, what would happen is that immune response that kicked up and tried to fight off the bacteria would also fight off the sarcomas or bone tissue tumors or melanomas in some contexts. And so the idea was that this gentleman discovered around the late 1800s was that maybe the immune system is doing something to target cancers, and we just need to find a way to manipulate that appropriately so that we can help patients with different cancers. And we don't want it to be to the point where they have to get an infection to then kick up the immune response. We want to be able to help tweak the immune response earlier so we can treat the cancer. And this is a picture of a cancer cell in the middle with a scanning electron microscopic picture and a cytotoxic T cell, or one of the cells of the immune response. And the immune response is constantly patrolling the body like little police fighters trying to find the bad guy, if you will, and the bad guy being different cancer cells. And these T cells here are shown wrestling with and trying to destroy this cancer cell. And the idea there is if we can find the right way to tweak the T cell so that it could kill the cancer cells, that would be a wonderful thing. This is a picture of what actually is happening on a biopsy of a patient with a particular cancer. You can see on the top these kind of abnormal looking cells. They almost look like little fried eggs or funny looking eyes. Those are tumor cells. And at the bottom, all of these little tiny black or kind of dark purple cells are lymphocytes. So those are cells in the immune response coming up from the bottom of this picture up into the tumor at the top, trying to kill it. And kind of this is a T cell directly killing a cancer cell. This is a bunch of T cells trying to get into this tumor and kill it. So the idea here is we have to find a way to make these tumors visible to your immune system. Your immune systems are really great at fighting viruses, and we heard a lot about the immune responses and COVID infections and such. Immune systems are pretty good at fighting bacteria, but they're not so good at fighting cancer in the ways that we want them to be, or if they were perfect, no one would ever have to deal with cancers, and that would be a wonderful thing. So this is a tumor, and the reasons that the immune systems can't fight tumors exactly right is that sometimes tumors are hard to see immunologically because they're embedded within normal healthy tissue in our body. And we want our immune system to fight off the tumors, but we don't want them to fight off normal healthy tissue. And here's a tumor that comes from, let's say, a normal melanocyte, and normal melanocytes look kind of like melanomas. And so sometimes you can't tell where the tumor begins immunologically and where the normal healthy tissue ends. And so the immune system can't zero in and focus on a tumor and kill it. And so a lot of the treatments that we give with immunotherapies are intended to try to express the antigens of the tumor or make them visible to an immune response, so that if we can see that there's this tumor in normal healthy tissue shown by these red triangles here in a cartoon, and that is something that looks different. Okay, if I'm an immune response, now I see that this thing looks different. I'm going to zero in, I'm going to bring in T cells into the tumor microenvironment, or to where the tumors are, and try to kill the tumor with those T cells attacking the tumor, as you saw in that picture with all those little purple cells at the bottom trying to go up and get into that tumor to kill it. But the idea is you have to make the tumors immunogenic so that they are recognized as foreign and shouldn't be there in the body, and so the immune response can go in there and kill them. And a lot of the immune therapies that are currently FDA approved are intended to do exactly that. There are ways that we're giving drugs that enhance the T cell activity, and I'm not going to get through all the details of all these letters and numbers. I don't think that's really relevant to our discussion tonight, but there are drugs that are FDA approved that maybe many of us have taken, such as pembrolizumab or nivolumab. Those are drugs that block PD-1 on T cells that make the T cells more active, or drugs like relatlimab or ipilimumab. Sometimes those are given in combination with drugs that block PD-1. So all these strategies are trying to make these T cells better melanoma fighting cells. And we first explored these in melanoma, and they showed great effects. And now they're FDA approved for many different types of cancers. And in some situations have even been shown to help prevent recurrences of melanoma after resection of high-risk melanoma surgically. So the idea of all of our treatments for melanoma is increasing the immune system's visibility of the melanoma. And this is a patient with melanoma on the arm. And one of the ways that's being explored to try to treat melanoma is giving drugs intravenously to hopefully awaken the immune response. But the other thing that can be done is injecting melanoma tumors with different substances that make them more immunogenic. One of the FDA-approved treatments is called telimagene laheparvec or TVEC. And I'm not going to go through all the details of how it's given, but it's an injection of a herpes virus that's genetically modified into a tumor cell so that it can cause the tumor cell to explode. And by exploding and that death of those tumor cells, it elicits an immune response to say, all right, something's going on here. I'm going to go in there and try to mop up that exploded cell and that damage. And the idea is that that'll enhance the immune response more globally in the patient. And in situations where immune therapy might not be working, there have been a lot of different strategies of combining these types of injectable genetically engineered viruses into tumors to make them more immunogenic as one strategy of combining new drugs together for patients with melanoma, especially if the immune therapies haven't worked well. And this is a situation where there's a lot of new drug development and exciting new advances. There's a whole field of research of better engineering some of these viruses to be even more immunogenic. There are, this is not FDA approved, but there's a compound called RP1 that's in clinical trials and showing some really interesting efficacy in people for whom their initial immune therapy strategies have not been successful. This is what it looks like to get an injection into a tumor site that is on someone's limb in this particular context. But these injections of these different modified viruses can be done inside the body as well if the appropriate clinical teams are in place to do injections into melanoma that's in the liver or other internal places too. So this is one strategy of awakening the immune response to try to help treat patients with melanoma if immune therapy is not working. Other strategies include more advanced modalities. There's something called tumor infiltrating lymphocyte therapy that can be given in situations where an initial immune therapy strategies are not working. And I'm going to kind of simplify a really complex treatment modality with the idea that essentially you have to pick patients that are appropriate for this because this is a complex treatment. But what is done is that the tumors are surgically resected. And the lymphocytes, remember I showed you those T cells that live within those tumors, they're extracted from the tumor, treated in a laboratory, and that's what's shown in this box here at the bottom, and grown in the laboratory and treated with special food called cytokines that makes them proliferate and become melanoma-fighting cells. And then that's infused back into the patient after the patients have received some chemotherapy. And the patients then subsequently receive something called interleukin-2 or IL-2, which is a treatment that boosts the body's immune response. And the idea of this is to take out the patient's immune response that's already trying to fight the melanoma cells, make it a better melanoma fighting army, and then reinfuse it back into the patients to help them fight their melanoma. This is typically done at specialized centers. This is not something that can be done everywhere around the country. We're excited at Sloan Kettering that we can offer this on a limited basis for the right patients. It's still in clinical trials, so we have to, we can't take all the patients as quickly as we would like for this modality, but it is something that can be considered in the right situations if immunotherapy is otherwise not working. We usually start treatment with a PD-1 based immunotherapy like pembrolizumab or nivolumab, as was mentioned earlier, but this is another strategy like the viral injections that can be considered if immune therapy itself is not working initially. So I'm going to tell you about one or two other strategies and then close on time in a few minutes. But uveal melanoma, that's another kind of melanoma that comes not from the skin, but it comes from the melanocytes, which, as I told you in the beginning, they don't just live in the skin, they live all around the body. And they do live in the tissue behind the retina too. This is a picture on the left of an eye doctor looking into an eye, and this brown spot on the left of the picture is where the melanoma is in this patient's uvea. And essentially, there's a new treatment that's out, and I'm not going to get through the details, but this is the first FDA-approved treatment for patients with uveal melanoma. It showed it helped patients live longer with uveal melanoma, which is a wonderful advance, but it's a drug called tebentafusp, and the intent of it is to bind one side of it with the uveal melanoma cells and the other side to bring T cells into the tumor microenvironment. So it's a T cell redirector. It gets the T cells in the right place, but patients have to have the right type of genetics for this to be an applicable treatment modality. But again, a new strategy that we're doing, and we're testing clinical trials of how well this works for people with the routine skin melanoma. So a huge advance for patients with uveal melanoma that was FDA approved last January in 2022. Again, exemplary of all of the new advances that are coming forward in melanoma across the spectrum. And this is the first time this drug has been FDA approved. And now there are many clinical trials for people with lots of different kinds of cancers with these types of drugs. And I'm proud to say that in uveal melanoma, this is a pioneer example. So I wanted to end, as we think about new treatments, we always want to do better than the current status quo. Our treatments can help a lot of patients, and we've come a long way, but we need to do better. Until we help every single patient with melanoma, we're not finished. And so we're doing a lot of clinical trials, testing new approaches. And a lot of times people have fears about clinical trials. It means, well, am I going to be getting a placebo or an inactive treatment? And I would say that that's not an ethical trial on patients with melanoma. Almost every trial in melanoma that's running right now is the best treatment that you would otherwise be doing, plus a new investigational drug that we think will actually increase the efficacy of the best available treatments. Sometimes trials are done when there are no other good standard treatments that are available, but a lot of times it might be the first thing that one tries for melanoma, or some kind of new combination that is intended to build upon the current standard of care. And again, it's not a test of a placebo or an inactive treatment versus effective treatment. There are very, very rare exceptions, but in these situations, that needs to be clearly explained. But clinical trials don't mean placebo. And I have a cartoon, if you forget everything, this is how sad I would be if I had heard that there were placebo-controlled trials for patients with advanced melanoma. This is, honey, go talk to him. He just found out he's a placebo. So this is like the little family of pills. And I apologize for the corny humor, but I figured that that would be appropriate kind of toward the end of my talk. And really to stress the importance of that, although you might hear about placebo trials in melanoma or treating advanced disease, that's almost always you get the standard of care treatment, which is what you'd be doing anyways, plus something else. And sometimes there is a placebo when it's the standard of care plus placebo, or the standard of care plus another experimental drug. But don't think that most trials are placebo-controlled trials, because that's just not true, especially instead of advanced melanoma. So if immune therapy or other treatments for melanoma, like the BRAF-directed treatments, as I was telling you before, are not working, we always want to think about, is surgery going to be applicable? Is radiation therapy applicable? If a BRAF mutation is present, great, you can treat that with pills. If it's not present, I don't tell patients that that's a bad thing. It just means we have to treat it differently with different immune therapy strategies. There are ways that we're trying to study why people have different types of mutations, and why might be the best ways to target those mutations. And with new immune therapy combinations, we're hoping to bring more T cells into the tumors, make those tumors red, if you will, with those little red triangles, and more immunogenic, so that the tumors can be seen by the immune system, and the immune system can seek and destroy them. And I would always give a plug to clinical trials, because it's not only the best treatment for an individual patient in some situations, it's also how we help future patients in subsequent years and further advance the field for everybody to come in the future. With that, I will thank you for your attention. We're going to turn it over to our patient, who I know will have a really enlightening discussion. We have some additional time following for questions. And this is our melanoma team in the virtual era at Sloan Kettering Cancer Center. And again, my name is Mike Pasta. I'm the chief of melanoma at Sloan Kettering. It's a real privilege to have an opportunity to speak with everybody tonight. And thank you for your attention.
Thank you so much, Dr. Pastow, for your presentation and explaining this to us in a tangible way. I definitely appreciate that. I look forward to the questions that the audience has for you. And I just wanted to note that I incorrectly introduced Courtney Kramer. So sorry about that, Courtney. Courtney is the Associate Director of Marketing at Replimune. Thanks for being here, Courtney. So tonight we are so lucky to also get to hear from the patient perspective, like Dr. Pastow said, the patient voice this evening. So Benny Lunsford has had stage 4 cancer since 2013 and stage 2 in 2005. He has pretty much done all of the treatments you can think of. He has a wife, Janet, that he owes his reason for still being here. She was the one that was instrumental in finding a trial and treatments that allow for him to be here today. Benny has 2 children, Colby, who is 13, and Emmy, who is 16. He lives in Houston, Texas, and is the IT director for an engineering firm. Thank you for joining us, Benny.
So thank you, Dr. Postel. It was a great presentation and hit on a lot of the drugs that I've taken and through the years and different treatment options. So I'll kind of give you a quick rundown of what I've went through and where I got, or how I got to where I am today. So in 2005, they found a mole on the back of my arm, and so they removed it. I went to MD Anderson. They did a sentinel node biopsy where that was all clear. So they followed me for, I think, 5 more years, do a chest x-ray, that kind of thing, said you're good to go. About 8 years after that, in 2013, January 2013, I noticed I had a lump in my hip muscle. So I went to the doctor. They're like, didn't you have melanoma? And I was like, yeah, that was a long time ago. It was like 8 years ago. What does that have to do with anything? So they were able to do a biopsy and realize that it was, melanoma. During that time, we went back to MD Anderson. They wanted to put me on IL-2. So before I did IL-2, they told me about TIL. So they went ahead and harvested another tumor that had appeared in my shoulder blade in between getting diagnosed. And then, so we had a tumor that we could harvest. So they harvested that for TIL just in case as a backup plan. So I did 2 rounds of IL-2. It didn't work. So then I was, so the cells should have grown while I was doing IL-2, but they told me that TIL didn't work. So the cells didn't grow for me. IL-2 didn't work. So at that point, it had already spread to my bones, my liver, my lungs. It ate holes through my bones. It was pretty much everywhere in my body. I looked very similar to the picture that he put up there. So at that point, they wanted to put me on a BRAF inhibitor and biochemo at the same time. It wasn't technically a clinical trial, but it was something the doctor thought because I was young, healthy. It's something that I could probably handle pretty well. I didn't feel too keen about that. By that point, my wife had reached out to a bunch of different Facebook groups, some other caregiver type situations, and I'd pretty much stuck my head in the sand and didn't want to deal with it. I didn't want to research about it. I didn't want to know anything about it. I just didn't want to deal with it. And she took the other mindset of joining all these different Facebook groups, talking to different people, then getting on clinicaltrial.gov, just kind of burying her head into, putting on research mode instead of burying her head into the ground. And so she found a doctor at Moffitt in Tampa, and that people really liked. So we talked to him for a little bit. He's like, well, if you come here, we can have a meeting, talk, that kind of thing. He went over the BRAF inhibitor biochemo, and he didn't really agree with it. He thought it'd be too toxic. So whenever I went back to Houston, I just went with the BRAF inhibitor instead. So we didn't do the biochemo. It actually worked really well. All of the cancer disappeared. I looked like the person on the right side of that picture. So they continued doing that drug. For most people, that drug has a life and it stops working at some point. Mine, it actually started causing my kidneys to fail. So they were able to, they took me off of it for a month or 2 to kind of let myself heal. I ended up having some headaches and different things in about December of 2013. And so at that point, I went to the hospital, realized I had a brain tumor. It was a 3-centimeter brain tumor. So they put me in the ICU, did a craniotomy. They followed that up with a gamma knife to treat the surgical bed to get anything that they couldn't get from the surgery. But at that point, there was pretty much out of options. PD-1 existed, but I didn't have enough cancer because it had been previously resected. So I didn't qualify for any trials. So they wanted to put me on Temodar, if I remember right. And that I didn't really want to do that either because it doesn't really work and the other things. So at that point, I reached back out to Moffitt and to see what other options exist. MD Anderson didn't have any trials. I didn't qualify because technically I didn't have any cancer. But it was still there. It didn't go anywhere. So I went there and they actually had a 10-person trial for an adjuvant for people that had previously resected brain tumors or tumors in general. So it was a very small trial. I was able to get on that trial, and at that point, I was on it for 3 years. Didn't have anything come back. And on that trial, it was a PD-1 trial along with IPI, and it worked pretty well. So, from that point forward, I've been, I had all my scans have been clear. I think it's been almost 8 years now. 2016 is about whenever I stopped going to the trials. So everything's been clear. So since then, my wife's been on different support groups. I joined all these different support groups that really helped me during that time to gain that knowledge from other people that are going through it. I wouldn't have found these doctors without talking to other people. So I became an advocate for other people to help them try to find, put them in connection with a doctor, or this treatment, or you've heard about this or that, because doctors are great, but a lot of times they're focused on their trials, that kind of thing. And sometimes, you have to go for that second opinion. You got to talk to other people. And so I've been with Intermittent Angels also, I probably mentored maybe 10 or 12 people over the years to help them through, because all these big words, it's confusing. You don't understand it. You get home, your head's spinning. The doctor told you all these different things. You're trying to Google it. You don't understand it. And having somebody else that's been there, it just means a lot. And, even if it's just a talk, but so I've done that. And that's pretty much it for me. So
Thank you so much, Benny. I have a question. Benny, did you have a mentor yourself, or how did you decide that you wanted to become a mentor for others?
did not. I had people in the Facebook groups that I looked up to. We talk and that kind of thing. But beyond that, it was somebody had posted on one of the groups and said, "Hey, we're looking for people to join as a mentor." I reached out to them, and then from there, I just kind of, anytime they needed anybody and I matched up with similar story or something like that, then they give me their number and we just chat about different things, questions, fears, that kind of thing.
And what is it like for you to be that mentor to someone else?
Sometimes it's hard. It really is. Not everybody's story is like mine, and but there are a lot of great people that I've met and been able to help them through this journey, and put them in contact with certain people that they can, something that they wouldn't have thought of, or it's okay, I'm about to have craniotomy. What's brain surgery feel like? And you joke, well, it's just brain surgery, but it you can kind of put their mind at ease a little bit and say, well, there aren't really a lot of nerve endings up there, so it doesn't hurt as bad as a leg or doing stomach surgery or something like that. It's tender on the outside, but it's pretty much, once you're done with surgery, you get the relief of no pressure up there. And obviously cognitive wise, it takes a little bit longer to heal, but other than that, it's actually pretty simple surgery.
That you're kind of just, people who come to you with fears, you're kind of telling them what it's like, and so that they can understand what it may be like to be, in the chair themselves or in the operating room themselves.
And sometimes, I'm honest too, where it's like, yeah, this one's gonna suck, and you're not gonna like it, but if it does work, then it's awesome. So
Yeah, well, thank you for being that advocate for others, and for being here with us tonight. We can turn to some question and answer now, if you'd like. If you had anything else to add, Benny, I'll let you finish. Okay, so Dr. Pastow, do you want to start with the first question?
Sure, and I'll take that question. Benny, thank you for sharing your story, and really appreciate all that you're doing to help other patients and families navigate this world. It certainly is a complex world, and I think we're all trying to find ways that we can try to streamline things so patients get access to all these opportunities that are out there. First question, I think, is if pembrolizumab is not working, is it possible to change to nivolumab, or should we add ipilimumab? So pembrolizumab and nivolumab are really the same drug. It's not the same drug exactly because they're made by two different companies, but I like to call it Coke and Pepsi, if you will. Maybe some people have a particular flavor they like a little bit better, but they're really kind of the same thing because they both work by kind of blocking PD-1. So if pembrolizumab isn't working, it probably wouldn't work just to change to nivolumab by itself. So usually in these situations, although there are many different strategies that can be considered if pembrolizumab is not working, many times there's a change or usually an addition of ipilimumab to ongoing PD-1 blockade after drugs like pembrolizumab or nivolumab have been given. So it's not always the thing to do next, but in many situations, if someone's been on, let's say, nivolumab by itself, and it's not really working, instead of switching to pembrolizumab, many times patients will get both nivolumab plus ipilimumab in that particular context, because ipilimumab is a different type of immune boost. So usually we think about changing strategies a little bit if something is not working initially. Do you want me to take the next question too about mucosal melanoma, or?
Sure, go ahead.
Okay. Another question about what's new with mucosal melanomas, and can you do a TIL trial that we just heard about from Benny's experience, and also that I mentioned too, our trials with autoimmune disease, psoriatic arthritis. So a few different things in this question. I'll take one piece of this at a time. First, mucosal melanoma. So melanoma, I showed the example of that mold that's on the skin, and the skin melanoma is the most common kind of melanoma, but it gave you the example of the melanoma that can start in the back of the eye called uveal melanoma. And because these melanocytes that I showed you, those little octopus-like structures, they live everywhere in the body, they do live in mucosal linings as well. And melanoma that arises from those areas is called mucosal melanomas. Many times they're initially treated the same way as skin melanomas, so immune therapy can work for mucosal melanomas too. PD-1, either by itself or in combination with relatlimab or ipilimumab upfront, is typically given for mucosal melanomas now, that if it's in a kind of a more distant location. So that's something to think about. There are new clinical trials that are being done for mucosal melanomas also. So there's a couple of drugs in clinical investigation that work through IL-2, and Benny mentioned one of the IL-2 drugs that had been given in the past. There's some new ways that we give IL-2 therapies that are intended to minimize some of the toxicities and hopefully help boost the immune response in different ways than the standard IL-2 that had been given in the past. One of the new IL-2 drugs that's in clinical trials is something called nemvaleukin. Kind of a complicated word, but it's a modified IL-2, and it actually has breakthrough therapy designation for treatment of mucosal melanoma. So that's one kind of example of a new strategy that's being done for mucosal melanoma. Can you do a TIL trial or other trials if you have autoimmune diseases like psoriatic arthritis? So each trial is very specific about whether or not certain types of autoimmune disease situations are allowable in the trial. I think we need more trials for patients with autoimmune diseases. Those are so common, whether it be Crohn's disease. My mom actually has Crohn's disease, so this is something I've grown up my whole life being around. Psoriatic arthritis, also something that people have to deal with, and then they also have melanoma. So I think we do need more clinical trials for people with autoimmune diseases. But sometimes when these drugs are being explored in earlier settings, particularly like the first time something's being done or new combinations, there's a bit of a hesitancy to treat all patients with autoimmune diseases because of potential risks of some of these experimental drugs in settings of underlying autoimmunity. What I would say is never, if you have autoimmune disease, you still should be pushing, because sometimes certain autoimmune diseases are okay for clinical trials. So I would say it's on a case-by-case basis, and your doctor should really try to help advocate getting into an appropriate trial if there might be one that could fit, even despite autoimmune disease. There's certain situations where it might be okay, but I can't really give a general answer because it's so different from one trial to the next. Miriam, I don't want to monopolize the time, so if you want, however you want to handle the next batch of questions.
Yes, so there actually was another question towards the end about another autoimmune disorder, multiple sclerosis. So I guess kind of that your answer previously answers that question as well. Has there been any further research done on using immunotherapy with autoimmune diseases like MS?
So I think one message is immune therapy can work against melanoma in patients with autoimmune diseases, just like immune therapy can work against melanoma in patients without autoimmune diseases. So if immune therapy is the best treatment option for the melanoma, even despite an autoimmune disease, I tell patients it might be worth trying it. We have to recognize there could be higher risks of certain autoimmune diseases or some exacerbation of the underlying autoimmune disease when we embark upon that. But I think if the oncology teams are in close communication with whatever other doctors are helping take care of the autoimmune disease, that the side effect can be mitigated and minimized. So I think that the bottom line is that it's worth thinking about other options in settings of autoimmune diseases. But if really immune therapy is the best option and there's underlying autoimmunity, it is something worth talking to your doctors about risks and benefits. I can't really recommend it one way or the other in a specific case or comment on kind of an individual experience, but I think in a general sense, it can help. So worth thinking about despite the elevated risk in certain situations, if it's the best option.
Yeah. Benny, I'm going to ask you the next question about the caregiving role. You mentioned your wife, and I'm curious to know about your wife's experience as a caregiver, and if you can share any supportive services that you used. Obviously, you have young children, what you've used for support services in your community, at your cancer center, or online.
So primarily, she joined a couple different Facebook groups. And within there, people put her in contact with other caregiver Facebook groups. And so for her, that was a huge thing because they only allow caregivers in those groups. So they could talk freely, they could talk bad about their spouse or, whoever it is, whenever they're having a rough day and be like, he's being a jerk because they put him on steroids and he's jittery and he's angry and blah, blah, blah. How do you deal with him? And they can talk freely over there. And then we have our support groups where we can talk. And so it gave them an outlet to at least, it's hard on a caregiver. And, it's hard for the person with cancer, but they're living next to you and not being able to do anything about it. And they're dealing with all the same stuff you're dealing with. They're just not in the pain or that type of thing. So, but that's how she was able to kind of get some relief from just the day-to-day and everything. We did have some help with social workers with our kids to kind of help explain it to them. At that point, they were pretty young. My son was probably 3 and my daughter was 6. So they didn't quite understand it. They didn't understand why I had to fly to Florida every other week for 3 years, but the other side, we just kind of downplayed it, and they really didn't understand the gravity at the time. They do now that they're older and we can explain it to them, but but no, it's difficult sometimes. Did I answer your question?
Absolutely. Thank you, Benny. There were a few questions about scans, Dr. Postow. The standard of care for getting scans after no evidence of disease. Is there a standard of care for that? And you might not be able to answer this question, but understanding insurance coverage for PET scans.
It's a great question that comes up all the time in clinical practice of, how closely do we need to monitor a melanoma situation? Do we do scans every 3 months, 6 months, once a year? What kind of scan? CAT scan, PET scan? I think there's so many individual considerations with this. I think the main things that I try to consider is that CT scans and PET scans are kind of different types of tests. It's not that one is necessarily better than the other. I think they're good at different things. So I want to kind of be clear on that, because I know that there's a general kind of feeling that everyone likes to do PET scans for some reason. They're much longer tests. They're harder to do. You have to fast before. Sometimes they're definitely more expensive. So it is a little bit of a challenge. I feel comfortable with CT scans for most situations. Sometimes, a little bit different. CT scans you can see in the lungs and small little spots a little bit better than a PET scan can. PET scan gives you some functional information, so it doesn't just tell you if there's something there, it'll light up a little bit. And so if you're reviewing a PET scan with the doctor, you want to ask if something's there, is it lighting up? How much is it lighting up? Or maybe it's not lighting up. Those are the kinds of questions to think about between the two. In terms of how frequently to do them, it really depends. If you're just starting treatment and we're kind of closely monitoring, I usually scan my patients. No, I don't go more than 3 months in that situation with new patients that are getting started. if people have been, many years out and everything's been fine for quite a while, I do space the scans out. The exact interval depends on the situation, how closely we need to monitor, sometimes every 6 months. Some of my patients are once a year after a certain period of time, after many years of being okay. And that's intended to minimize the radiation that comes from these scans. And sometimes scans can even cause problems because it lights up in a funny place, and then you have to do some extra testing, or creates a little bit of a panic when everything is okay. So there's a little bit of a plus and minuses for doing scans and how frequently to do them. But generally, when starting out with treatment, it's every 3 months at longest in between the scans with the new diagnosis of melanoma and really getting started with active treatment. That'd be the way I would answer.
We did do a talk a few months back on scanxiety for patients. So if you want to check that out, you can go to melanoma.org to our education institute, and you can watch that Ask the Expert webinar series session on scanxiety, because we know that comes up often for patients.
Yeah, it's a real tough thing because I know a lot of the results are being released right away to patients too. And so the patients are on the portal or otherwise looking at their medical records, and it comes up and there's all this medical gobbledygook sometimes, and it can cause a lot of anxiety to look at all these things. And I'm always trying to find ways in our personal practice to try to, I don't know if there is a good way. It might be, it's just kind of how the nature of this thing, but I think we're still trying to figure out the best way to scan, how frequently to scan, if new treatment things like circulating tumor DNA, which is, I know, being discussed a lot, could that be helpful in monitoring patients on treatment? It's still in my mind mostly a research test. I don't think we've fully known how to adopt that in clinical practice, but hopefully in the future we'll have ways where we don't have to use any radiation scans. We can know exactly how we're doing with the melanoma and find a better way to monitor.
That would be amazing. Absolutely. And yes, you never want to go to Dr. Google when you get your scans back without talking to your provider. So
yeah, I think we can try to provide a lot of context around a lot of the findings. In my experience, usually the scan reports things in a more scary way than is usually the reality, because some of the words radiologists use, they don't have the whole clinical picture of what's really going on. They've never met the patients. They don't know the history of the findings and how to context all of the things in the big picture. So it's a little bit like too many trees and not enough forest, if you know that expression, the forest through the trees. So I don't know if that helps reduce scanxiety. I think it's always going to be there, but maybe keeping that in mind might help if you're looking at results.
Benny, what do you have to say about scans and scanxiety? What do you do to mitigate some of those feelings?
There's not a lot. The only thing that really helps is if you're able to do the scans in the morning and meet the doctor in the afternoon. I think that's probably the best for me, is whenever we're able to set it up that way. That way you don't have to sleep on it. You don't have to, you just show up, you get your scans, you wait a couple hours, you go eat, you come back, you meet with the doctor, and then it's just kind of rips the Band-Aid off. Most hospitals don't operate that way, but if you're able to set that up, it does help a little bit. But overall, you still got to do it. You still got to go for your scans leading up to it. And I get pretty cranky and kind of myself together where I don't want to talk to anybody, that kind of thing. And my wife's kind of the opposite, and so it puts a lot of stress on the family leading up to it, because you just don't know. I mean, everything can change on that one scan. It doesn't matter how long you've been good for, and which mine, it was 8 years before it came back, and then and then it came back again. So I've had a couple false starts where you never know. So that feeling never goes away.
I appreciate you sharing that and kind of being candid with us here about your experience. And not only does it affect you, but it affects your family, your wife, and your children as well. Any final thoughts, Dr. Postow or Benny?
I guess I have a question for you, Benny. What would the medical establishment be able to do to help patients more? What can we do better? I know there are probably a lot of things, but what's, an easily achievable goal that we can do?
I think that, do you mean on the anxiety side or just in general?
In general, in terms of helping patients with melanoma.
I mean, and I know it's hard for the doctors, but being more educated, I guess, on what other doctors are doing. And I think a lot of times, a lot of doctors, they get focused on their research, their stuff, their trials, and they're aware of all these different things going on, but they kind of a little bit narrow-minded on some of the stuff that they are doing. And so for me, that was a major issue. And at least talking even outside of your core group, of your team, and that, having more meetings with other hospitals, that kind of thing, to where y'all are kind of sharing. And it might happen. From my experience, the doctors are just kind of hyper focused on their stuff, and it required my wife to basically go and research it all herself to figure out that even some of these things were existing out there. And from there, we were able to find a trial that worked for us. But without her doing that, it could have been a different story. So.
Thank you for sharing that. And I think it speaks to the point and the importance of multiple opinions, different places.
Yeah.
Absolutely. And thank you for sharing, Benny. I'm sure that was a loaded question, and we could kind of talk some more on that topic, and appreciate both of you for sharing with us this evening. So with that, I'd like to thank you both for being our speakers today in our Ask the Expert session. We appreciate all that you do for the melanoma community, and appreciate you taking extra time to be with us this evening. Thank you again to Replimune for their generous support of our Ask the Expert webinar series. Again, this program will be available on demand on our learning platform, and also streamed on our social media channels at a later date. At the end of today's program, when you close the Zoom, a pop-up browser will pop up, and that will be your survey for tonight's session, just an evaluation based on your experience in today's session. Your feedback is so very important as we continue to plan these educational sessions for you all. Please visit melanoma.org to learn more about our upcoming webinars and other educational or advocacy opportunities. And as always, if you have any questions, please feel free to reach out to me at education@melanoma.org. Thank you so much for joining us, and have a wonderful rest of your evening. Take care.
Bye, everybody.